the main challenge is, again, not having the right clinician name on the requisition form, not knowing exactly what the priority of sampling is. Many times it's not only for diagnosis, but it might be a repeat biopsy or FNA or whatever procedure done specifically for molecular testing, and there is this miscommunication between clinicians and the pathologists, and we don't know because that information is missing from the requisition form that test was specifically repeated for molecular testing. Then other issues might be, especially in small biopsy and cytology sampling, not having enough material for molecular testing, especially when there is no other prior diagnosis. So if the tissue is very limited, we might have consumed all the material for immunohistochemical studies to be able to make a diagnosis first, and therefore limited material left for molecular testing. Then another issue, potential issue, is various platforms for molecular testing requiring various amount of tissue for their panels. For example, if the panels are very extended, like let's say 400 genes, obviously the request for tissue is more than in a panel with very limited genes, which is like more targeted, but also at the same time requesting less tissue. So again, it comes back to not having enough material for testing, again, based on the platform used. So I think this would be the main reasons. Sometimes we don't have the results expected by clinicians, and I don't think they always realize how much tissue is needed for specific platforms. And I suppose because there's also limited exposure to pathology in medical schools, they don't really understand that sometimes we do require tissue to perform all these additional studies in order to be able to point to a primary or like to the diagnosis itself.